I'm Louise Field, founder of Adore Your Pelvic Floor, and we provide training days to the health professionals and also a pelvic floor program to women in the community. And we have the lovely Diane Danzebrink. And
She's done it again.
Danzebrink.
Bless you, you'll get there, honey.
Oh, the menopause counsellor for women and for couples, and also consultant in the workplace for businesses and organisations. Diane has also founded this campaign, Make Menopause Matters. Please look it up and see what it's about so that you may then make that choice to sign the petition so that we can then get some education out in the UK. So this video is about hormones. It is about, excuse me here, okay, because I have to go through the consonants.
That's
Progesterone.
That's it.
Estrogen and testosterone.
That's the one.
So can we please hear out more about what is progesterone?
Okay, so what does it do?
That hormone?
What does it do? Okay,
what is its
so
function?
progesterone is really the hormone that during our reproductive years helps to sustain a pregnancy.
Okay.
And it also helps to regulate the monthly menstrual cycle.
Oh, so it's that
So
one.
that's kind of two of its
I'm
main
going to learn
jobs.
so much on this one. Oh, so I'm going to have all these new friends. Oh, that's what my progesterone is for.
So that's two of its main jobs.
Okay.
But some of the things that people might not know that it does are that it also helps to act as a calmer for the body.
Okay.
So when we go into menopause, progesterone is the first hormone really to start changing. So it drops quite hard and quite fast. So consequently, a lot of women talk about having psychological symptoms in menopause.
And would it also be
So that
your mood
makes sense.
swings as well?
Can do, yeah. Also, progesterone also helps to promote sleep. Okay. So a lot of women talk about their sleep pattern being broken.
Okay.
So, you know, there are several things that are going on during this time, and when you know what the hormones do, it kind of starts to make sense.
Yeah, really. So going back then when you are having your period, so you your hormone progesterone.
Yep.
Is that what would be your mood swings?
Yeah, I mean, so for some women, they are very much more sensitive to the hormone changes than others.
Well, they got the frying pan and hitting somebody with it.
Yeah, so some of us are very much more sensitive to others than others to their natural hormone changes. So yeah, you know, kind of it's a really complex picture.
Yeah, absolutely. Okay, so can we now learn what the hormone estrogen is all about?
Well, estrogen's a really interesting one because
we're not going to get too scientific.
No, we won't. We won't get scientific because estrogen that we produce 3 types of estrogen.
Okay.
So we produce estradiol, which is the most potent of the 3 and the one that's causing havoc at menopause. We produce estrone and estriol. Okay. But estradiol estrogen is the most amazing hormone because it does so much in the body. Women have estrogen receptors all over their body, so literally from your head to your toes. So it does things like it helps with joint mobility. It helps to promote bone health. It helps to maintain our heart health. It has a huge amount to play in the brain, and we're actually only starting to learn just how important estrogen is to the brain. So it helps with our serotonin levels. It helps with our neuroreception. The pelvic floor is very reliant on estrogen. So for a lot of women, when they go into their perimenopause, postmenopause years, they find that the symptom that they really struggle with are things like repeated UTIs, urinary tract infections, or vaginal atrophy, vaginal dryness, etc., etc., which can be hugely debilitating and have not just a physical but also a psychological effect on women. So estrogen is responsible for all sorts of things like a lot of women talk about having dry eyes or dry mouths.
Yeah.
In menopause. That's because of your estrogen fluctuations. Itchy skin. That's because of the estrogen fluctuation.
Okay.
You know, struggling to get up off the sofa because, you know, kind of your joints are a bit achy, etc. That's all to do with your estrogen. So it's a hugely important hormone.
And so, like, say you had the dry eye thing, and you've had your menopause day.
So you've had your 12 months without a period in your post.
Yeah. And now you're in post. Would things like the dry eye thing disappear? It wouldn't, would it? Because you still haven't got estrogen.
No, not necessarily, because what's happening, so if you think during that perimenopausal phase, the progesterone level falls and it settles relatively quickly, but your estrogen is then literally going up and down, sometimes on a daily basis.
And that's why they now say a blood test doesn't necessarily give you a full picture.
So a blood test after 45, there's really not a lot of point.
And is that because of the...
Yeah, because most women are perimenopausal by the time they're 45. So if your doctor takes a blood hormone profile on one day, a couple of days later it could look very different.
Okay.
So actually, menopause should be diagnosed on symptoms alone.
Yeah.
So I always say make a list of all your symptoms is a good idea. So yeah, I mean, I don't think we can kind of overstate the importance of estrogen to body function and body health.
So going back to the question
Yeah.
of dry eyes.
Yeah.
is, so if
Would
I
it
was
resolve?
70, would it resolve?
It depends where your natural hormone levels settle out. But if you're struggling with it in perimenopause, it's unlikely. You will probably need some kind of treatment for it. I'm going to sound a bit like a broken record, but what you probably need is hormone replacement.
Okay. And obviously not all dry eyes are down to
No,
this.
absolutely. And that's why it's important to see your doctor to see if there's or if it's just your eyes, your optician to see if there's anything else going on.
So tell me more about the hormone testosterone.
So testosterone is typically thought to be a male hormone, but women produce testosterone too. And testosterone is always thought about in relation to sex drive. But actually testosterone is much more complex than that. So it does help to support libido, there's no doubt about it. It also helps to support our bone density, helps with our cognitive function, how sharp we feel, and also helps with how we feel about ourselves. Also helps with self-confidence. So for me, you might not believe that I struggled with self-confidence, but when I had my hysterectomy, so had my ovaries removed, so the main production of my testosterone was gone overnight, along with my estrogen. Once I had my estrogen level was right, or right for me, I still felt as though somebody had sort of extracted the self-confidence chip and thrown it away. And it wasn't until I got supplemental testosterone that came back. So that was the key for me, was having that added in with my estrogen.
And from one of your other videos, you were saying that you had no, you didn't have progesterone.
No, because I don't have a womb. So.
But you had your estrogen, and you had to wait a few months, 6 months before you put in that testosterone.
Yeah, so there's quite a complex interplay between estrogen and testosterone. So you have your estrogen for a few months and see how that affects things, and then if you're still struggling, and as I say, for me, it was really as if somebody had just, chucked the self-confidence chip away.
Which is so important.
Absolutely, because how we feel about ourselves
affects everything, doesn't
absolutely. It? So, and as I say, cognitive function, how sharp we feel, how able we are, kind of to do our jobs, etc. Also helps with muscle health. So, you know, kind of, again, quite a complex picture.
Yeah, okay. The different types of medication.
Yep.
So we are talking of HRT here.
Yep.
The different types of medication available. So there's gel, and there's plasters, and there's oral, and then there's this, I call it the squirty cream up your...
Oh, the vaginal estrogens.
Yeah,
okay.
the squirty
So we have a whole range. There isn't a one size fits all. Very much depends where you are in your menopause journey. So if you're a woman who has had hysterectomy, so you've had your womb removed, you could have estrogen, but you don't need progesterone.
No.
If you've had your womb and your ovaries removed, again, it's estrogen only for you, because you don't have a womb to protect. So progesterone has a protective effect on the womb. If you're a woman who still has, you've had no surgery, you have to have estrogen and progesterone. So estrogen comes as, if you're just having estrogen, so you're a hysterectomized woman, you can have your estrogen as a patch, a gel, or a tablet. The patches and gels, obviously they're transdermal, so straight into the bloodstream. Tablets go via the first pass gut and the liver. So there's a discussion with your doctor to have and a choice to be made. Some of those products are more suitable for some women, depending on family history. So there's a choice to be made there. If you're having estrogen and progesterone, you can have a combined patch, you can have a combined pill, or you can have your estrogen gel or a separate estrogen patch with a separate progesterone. Again, very, very much not one size fits all, and all those things come in different doses. So starting very, very low, going up to higher, depending on what each individual woman needs. If you're a woman who is still having bleeds on a fairly regular basis, you would have what's called a sequential regime. That means that you have your estrogen all the time and your progesterone just for 12 days, and that then produces a monthly bleed. If you're a woman who's post-menopause, so that means you've had 12 months without a period, then you would have your estrogen and progesterone all the time, and then you wouldn't be reintroducing monthly bleeds when they'd stop naturally. As far as vaginal products are concerned, there is like it's a little tiny pill. It's a pessary. There's also a couple of creams, and there's also a vaginal ring. So that's a tiny little ring that is inserted and lasts for 3 months and gives a regular dose of estrogen. What's called Vagifem, that's the little pill that's used for 2 weeks solidly, and then a minimum of twice a week. Some ladies need to use it a little bit more. And the creams, again, usually it's an introductory dose and then used on a regular basis. So there are all sorts of things, but as I say, it's not one size fits all. It's, you should, when you go and see your doctor, they should talk to you about all the options. I can't guarantee that will happen, because one of the aims of the campaign is to improve GP training in menopause, because unfortunately there isn't a mandatory training at the moment. So I would say, where you can, try and do some research, see what's out there, and see what you think you would like to try, and then have that discussion with the doctor.
Okay, no, that's cool. Hold on, let me get this right. Getting the dose right.
Yeah.
I take it it's really on your past medical history.
Partly.
And then beginning small and adding in if need be.
Yeah, so past medical history would definitely have a part to play. So if you're somebody who has a complex medical history, so whether that's a complex personal history or complex family history, it might be that your GP feels that an onward referral would be the best case. So that would be to a BMS menopause specialist. Sadly, we don't have enough specialist menopause clinics in the UK on the NHS. But there's 40 odd scattered around the country.
And I'm hearing women going to these clinics, so people are getting referred.
Yeah, so you have to be referred by your doctor. Yeah. But if you have, as I say, if you have a complex history, your doctor might feel that it's appropriate for an onward referral. If you're pretty straightforward, you're a healthy woman, you don't have any complex history, and there's no reason why you can't have HRT. Essentially, the sort of the rule is that your doctor should start you on the lowest possible dose. You have that for a period of 3 months, and then you have a review and look at, okay, what are my symptoms like now? Do we need to increase the dose? Yeah. So it's generally starting at the lowest possible dose, whether that be patch, pill, gel, a combination, whatever. But as the patient, you should have a say in that.
Cool. That's lovely. I'm just reading my question.
That's all right, lovely.
Side effects of too much of any one of these hormones.
Okay, so it's more about. So if you're starting low,
then that
shouldn't be in that situation. No. I mean, the one kind of caveat I would say is that we have seen cases where women have been to private clinics, where there have been issues around dosing. But with licensed products from your GP, if they're starting you on the lowest possible dose, or the lowest possible dose appropriate to you, so it would not have been appropriate for me to start on the lowest dose that a woman in natural menopause might have started on, because I'd had my ovaries removed. Yeah. So that wouldn't have made sense. No. But for the lowest dose that's appropriate for each individual woman, it's fair to say that some women do experience some effects in the first few months. There's no doubt that some women do. Some women find that they're experiencing breast soreness. Mm-hmm. Some women find that they experience some bloating. Women will tell you probably a host of different things that they think are related. Some are related, some are actually, it's coincidental. Yeah. But generally, if a woman gives it 3 months, for most women, they will find that all those things settle. It's not fair to say everybody, but for most women, those things will settle.
That's cool. So, let's see. Is there a time limit on how long we can be on HRT?
The simple answer is no, there isn't. The more complex answer is that there is still very much a thought amongst a lot of healthcare professionals that you can only be on it for 5 years, or you can only have it for a short time. NICE guidelines clearly state that a woman can take HRT for as long as she wishes to, but she must have an annual review. Yeah. So again, that's quite a tricky one, because a lot of women that have been taking it for 10 years or 5 years, etc., will get in touch with me and say, I'm really panicking because my doctor's told me they won't prescribe anymore. And it's like, hang on a minute. Now, let's point you towards the NICE guidelines. Let's get you to take that back to your doctor. Maybe let's write to your doctor and point this out to them and, sort of say to them, could they have a look at that? Because a lot of it comes down to knowledge. It's about updating knowledge. Yeah. And, it's not always easy to do. But I think the more that we know as women, the better it is. The more that we can kind of empower each other with that information, the better it is. And if there are good resources to go to, which there are lots of good resources, so certainly come and join the network. British Menopause Society has a part of the website which is just for patients. Royal College of Obs and Gynae has a part of their website which is all about menopause just for patients. You've got doctors like Louise Newson. My menopause doctor has a great website. So there are lots of things that you can, there are lots of resources to look at Can you always persuade your GP? No, you can't necessarily. But the more information you have, the better. And you might be really lucky. You might have a GP that's done some continued professional development training in menopause. So one of the things I would say is if you're going to the doctors for the first time to have an appointment about menopause, I did a lot of my training with practice nurses. So I would say, go along. Before you go, make your appointment, ring and ask the receptionist, is there somebody in the practice? So it's not necessarily the doctor, could be the practice nurse. Is there somebody in the practice who takes a special interest in menopause? And if they say yes, grab an appointment with them.
Yeah, makes sense. Absolutely. So there's lots of resources. Be proactive yourself and try to find the correct doctor. In the practice that specialises, that's their subject.
Absolutely.
Is there a time, right, so kind of, is there a time that we should come off HRT? Well, we've answered that one, but it's making that decision, when making that decision like, okay, so do I still need HRT? We know the benefits of estrogen for the body.
Yep.
So
how do you make the decision?
Yeah.
It's really difficult. It's really difficult because if you're thinking about coming off of it, you're probably on that continuous regime, which is where you no longer have a period, and hopefully your HRT has been optimized so that you're asymptomatic. You no longer have any symptoms.
Yeah.
So first of all, I would be having the conversation with a woman. Why do you want to come off of it? What's your reasoning? Everybody has to make decisions for themselves. So we'd look at, kind of what her thinking was. And also, so when do you do it? Well, actually, there isn't, sort of women who go into postmenopause, certainly before they're 51, they should certainly be on it until at least after they're 51. But now that we know more about the long-term effects of estrogen on our bone, heart and brain health, well, you need to be saying, okay, so look at the latest research on how that's protecting you long term.
Yeah.
And if you do really want to see where you are without it, then of course is there an ideal moment? No, there probably isn't. It's probably a case of, okay, so if you're not somebody that wants to take it long term, it's probably a case of stopping, seeing what happens. Am I really postmenopausal? Am I asymptomatic naturally? And if you start to get symptoms back, can you start it again? Yes, you can.
Okay. Well, I think that is been very well answered all the way through. Thank you very much, Diane.
Oh, you're very welcome.
So that was our video, Progesterone. Estrogen and testosterone. Thank you very much, Diane.
Oh, you're welcome, lovely.
Bye-bye.